Did you look him up at all?
You didn't tell me who it was.
We had an email with him.
I don't pay
It's
attention to the email.
clearly that is abundantly clear. Okay, he newly owns this practice, so we'll ask him a little bit about that. But I should. So basically, his
When
name
you
is
when you say this practice, just go back a second. What is this practice?
okay. So his name is Scott Guthrie, Dr. Scott Guthrie. He's an orofacial pain specialist, and he has his own practice called Midwest Jaw Relief, serving the Madison, Wisconsin area. So the real reason I wanted him was, I mean, partially because he's a practice owner, so we get to ask him those questions. And he said he's only 3 months in, so it's like really fresh. So I think that will actually be a good perspective on like he's in it. I'm sure a lot of guests like kind of forget, the challenges they had because they were so focused on getting through them. So it'll be kind of nice that it's fresh. But then also, so he's an orofacial pain specialist. Maybe he'll share more with us, but a lot of jaw pain, like TMJ pain and disorders.
Is there a residency in that?
Yeah.
Oh, wow. Okay. Is this all because of like grinding your teeth at
It's
night
not
type
all
stuff?
because of that, but that's like one of the things he'll treat for, which is so ubiquitous, which is one of the reasons why I wanted to talk to someone who specialized in this because I mean, every single patient I see, every person I know basically grinds their teeth at night. I know enough about if someone has severe pain, I'm like, go to the specialist. You know what I mean? But I don't feel competent as a provider if I'm kind of like, that's not my territory. You have to go somewhere else. Like, I want to feel educated in my recommendations. And it doesn't mean I'm going to treat them for this pain, but I can at least direct them and give them an idea of what to expect. I did a poll on our Instagram today of people who I was like asking who has had jaw pain and
And
clenching and things like
did all three of them respond?
we had several responses. Let's see. Today, we're joined by Dr. Scott Guthrie, a board certified orofacial pain specialist and founder of Midwest Jaw Relief. Scott is an expert in the non surgical management of TMJ, neuropathic pain, and sleep apnea. So, I'm really excited for this one because if you're like me, when a patient brings up TMJ pain, my instinct is to kind of like panic and refer. And Scott is here to help us move past that so that even if you're not the one who's treating the joint or the pain, with his help, you actually have better answers for your patient so they feel more confident, not only in you, but in their discomfort. And also, it's a great listen as a patient. Like all of us have experienced one or several of the symptoms that he talks about. So this episode really is for everyone. Hey, hey.
Hey, hey.
So did you learn a thing or two?
I did. I thought actually it was much more, interesting. I mean, some of the stuff was a little bit
I worried you were
clunky.
glazing over a little bit.
Yeah, no, I was reading the newspaper during part of it, but
For real?
no, no,
Oh.
not for real. One, I thought he's comes off as being an expert,
He seems
and
very knowledgeable,
I would
intelligent, all
feel
this.
very comfortable going to him for treatment. That's a good lesson learned for any kind of provider is that if you can make a patient feel that you're a subject matter expert and that you're confident about the care you're providing, I think is a very soothing kind of thing, especially for dentists.
And having his wife as social media, I mean, that's huge. What, like a burden lifted off.
Yeah.
If you could learn that in the meantime, social media and
Oh yeah.
graphic design,
Yeah.
if you could get on that, that would actually help me out a lot. I think we learned a lot, and I feel more confident in where to direct a patient based on what kind of symptoms they're presenting. Let's welcome Dr. Scott Guthrie to Medical Morons. All right, well, thank you for joining us. I know this was like so hard to get us on this game schedule, but we made it happen. I
Made it happen.
appreciate you working with us. I'm curious how you got into orofacial pain because maybe at your dental school it was more common. It was not common from my dental school. It was kind of like an avoided territory, I'd say, because it's a little intimidating. It's hard to get the results you want. So I'm just curious what got you into it.
I think I just got back from sim lab and was really frustrated. And I heard there was a lecture that night from a professor out in UCLA, their orofacial pain residency. And his tagline of it was dentistry without using a handpiece. I knew a little bit about TMD and thought it was interesting. Learned that there's an entire world of chronic pain conditions that I didn't know existed. I just kept diving in, finding it more and more interesting, and eventually applied to residency, shadowed, got in, and I continued to love it. So I'm going to keep doing it until I stop loving it.
After your residency, what did that path look like that got you to your private practice?
My second year of residency, I started planning this practice, trying to hit the ground running. We were trying to open up in July, and then just for a number of things, got started in September, seeing our first patient, and then really got into swing of things in October. I'd never even practiced general dentistry till it. And right now, I am working part-time at a FHQC, doing general dentistry there. I'm at my private practice 2 days a week, just doing pain here.
What is FHQC?
Yeah, so it's a government-sponsored Medicaid clinic. So it's a federally qualified health center is FHQC.
Got it. Okay.
You know, we've interviewed a lot of private practice owners at different stages, some who are 2 years in, some who are 30 years in. And I think for you, you're kind of in it, like it's happening as we speak. You know, you're trying to grow patients. So what do you find to be the most challenging at this point in time with the business aspect that you're kind of having to work through? Maybe you wish you had done something different from the start, or you're having to redo. So, you know, along those lines.
I think some of it is just figuring out what equipment I do and don't need and can't afford. For instance, today I just did a procedure on a patient, and I had previously told them, yeah, I can do this. I know how. I just need to get the machine. Didn't realize that the machine itself was, I think, $7,000. And based off the price that I told them I'd be doing it for, I'm just taking a loss every time I do this now. That's okay, but I need to figure out how to get on the front end of those kinds of things.
You leave your residency, you connected with these two consultants, advisors. Talk a little bit about the process of interacting with them. You know, did you go in completely blind and you know, unaware and uninformed and leaned on them heavily for guidance and kind of direction?
Very heavily, because when I was negotiating all of this, I was halfway through residency and I was living several states away. So that was definitely a challenge, just getting good advice on how and where to start the practice. Also with orofacial pain, not many people are doing private practice. There's definitely less than 100 nationwide. So there's not really a blueprint to follow as far as you need this, this, and this, and you need to do it in this order. But Alan and Justin both were very helpful, and they helped me find a really great spot as far as the space that we're renting. And there's an endodontist down the hall too. So
Great.
There's a lot of internal referrals going inside the same building, which has been great. Another really big difficulty was getting a bank to listen to me. Eventually Fifth Third Bank came through, but I went through like, I think 5 or 6 different banks until somebody finally gave me a green light. Yeah.
What was the experience like? Did they, was it like some guy sitting behind a big desk looking down at you and, you know, stamping, you know, rejected on the loan application? I mean, what was that like?
The people were always personable, I'll say that, but it was difficult because they have checklists. They say that, okay, a doctor that's been practicing this many years should be about this fast and should be able to do X amount of procedures, thus they can make this amount of money. And this is the deal that we can give you. But one, they don't have that for orofacial pain because they're like, okay, you should be able to do X amount of crowns. You should be able to do this many extractions. I don't even have water lines hooked up to my chairs. I can't do any of that stuff. So all of their models didn't jive with what we're doing. Fifth Third Bank finally listened and had more of a holistic.
They got your vision.
Yeah.
So can you tell us a little bit like what, because I don't really know how you make money, because when I think of orofacial pain, I mean, I think of it as kind of you're the diagnoser for the most part. I don't think of it, I'm not saying I'm correct, but as, you know, someone who doesn't know much about the specifics, I think of it, you know, for dad or anyone who's not in dentistry, I think of it as someone who's diagnosing what's the cause of your TMJ symptom. Is it your muscles? Is it the bone? Is it, you know, your teeth positioning, or for the neuralgia or all these different things that you could be experiencing? You identify kind of what it is, and maybe you'll do Botox or things like that, but it's not super procedural based in my mind. So how did you tell a bank, no, this is how we make money and why you should take a chance on me?
I kind of put together a spreadsheet based off of what I'd been doing in residency, saying that I'm going to see X amount of patients per day once I get in the swing of things. The bank understood that I was only going to be having a couple patients at a time. Out of every new patient that I get, roughly a quarter of them are getting bite guards, roughly a quarter of them are getting a CBCT scan. As far as procedures, how many times I'm going to be doing Botox, trigger point injections. And then there are a whole list of other procedures that can be done that, again, I didn't even know existed before orofacial pain. A lot of nerve blocks, joint injections, arthrocentesis. There are a number of things that we can do besides just diagnosis. But I think the diagnosis aspect of it is the brunt of the work. Once you know what's going wrong, then you can spend your time and effort towards fixing it.
Of course you treat all these different types of things. Can you talk about like the main things you're seeing, what that demographic is, and what you do about it?
I guess what I see is chronic pain from the neck up. So that is my demographic. I divide it up into jaw pain, nerve pain, and headaches. Typical patients are coming in with several years of chronic pain. We do get some acute pain every once in a while, but mostly I've been to 8 doctors, everybody's tried something, but none of it's worked. So what are you going to do different? Hopefully I have an answer for something that I can do different. Probably 50% of my patient base right now is I have my jaw aches, my joint is very painful. I can't eat tough foods. I want to be able to chew and smile without pain. Then the other 50% is the weird stuff, which I actually like more. It's what got me interested in orofacial pain to begin with. So that's the nerve pain, the headaches. So I've been getting a lot of those weird nebulous pain cases. Things like trigeminal neuralgia, things like atypical presentation of headaches. So before going to orofacial pain residency, I just knew about migraine and tension type headache. I didn't know that there's about 200 different types of headaches, depending on, again, what system you're using. A lot of those can present as toothaches. And if you just try treating it with a drill and it's actually a headache, it's not going to get better.
So going back to the jaw pain, because like I said, I think that's super common. I don't know why I know with or without reduction, but I don't feel comfortable when a patient comes to me and they say if I have jaw pain, I'm like, okay, go to the specialist. I'm not going to treat them regardless because that's not my specialty. But I feel inadequate as a provider being kind of like, I don't know, like playing hot potato. Can you give us a little bit of an idea of, as general dentists, dermatologists, anyone who's treating a patient and they say, you know what, I have some pain here, who they're not going to treat them themselves, but at least they can have the verbiage to ask them the right questions to see, what they should do next.
Sure. Whenever I get asked the question, what are the first steps? One, if it's acute pain, there's a good chance that it's going to go away on its own and you don't need to do a referral. The acute pain is anything less than 90 days. Once we go over 90 days, chances that it's going to get better on its own start going down. After that, I like to make sure that we're treating the right thing. So if you can ask them where they're feeling their pain. If they say, if they put a hand on the side of their cheek and I'm saying it kind of hurts in this area, very likely you're dealing with muscle pain.
Okay.
They put one finger right in front of their ear and says it hurts right here, very likely you're dealing with joint pain.
Amazing. And then what about a night guard?
You're very rarely going to hurt somebody with a night guard.
Mm-hmm.
When I typically like to do them is one of 2 scenarios. So if they're waking up with pain in the morning, likely they're doing something at night that's contributing to their pain. Mm-hmm. So getting the joint in a stable position, getting the muscles in a stable position is going to be helpful. The other case that I like using them is if we have a click that's painful, then I'll use a type of splint called an anterior positioning appliance that moves that lower joint back onto the disc and can help reduce some of that pain in the joint.
Got it. So if it's a click and it's painful, because that's another question we got, is that some people are experiencing a painful click and it freaks people out too. Right. Then that's another indication, but that's for an anterior positioning split.
Yes, yeah, which is different than a anterior bite plane.
Right.
Yeah, because I don't like partial coverage splints. If I'm going to use a splint, I want it to have full coverage.
That's actually really helpful because, yeah, like I said, it's nice to have like little like things to look at, like holding your your cheeks. I did a poll and I said, do you experience soreness when you wake up? And 78% of the responders said yes.
Mm-hmm.
So this is
Yeah,
speaking to them.
They'd be great candidates for a bite card.
Yep. And then have you noticed a pop or a click when you open your mouth really wide? 67% said yes, 33 said no.
So I always tell people 1 in 3 people has a click. It doesn't mean that your jaw joint is going to get worse just because it's clicking. And we don't typically need to treat a painless click unless it's really, really bothering you.
Got it. So, and then what about for orthodontics? The literature and what we study for boards and everything is always like, it mostly says that orthodontics will not affect your TMJ function and that we're safe to do it and we're immune to any lawsuits against it. But I'm curious, in your experience, if someone has an issue, I don't want to be like actively moving their teeth and messing with things. I'd rather that I think is accepted. Just like if there's any, pathology, you should be dealing with that first, of course. So what are some signs? Because I have a lot of patients with pops or with clicks, but I do treatment anyways because, like you said, it's super common. So what are some like guidelines that you would suggest for orthodontists?
I guess one is just before you start anything, I'd take a look at the condyles. I'm sure that you do. If we start procedures too early when those processes are going on and we're having joint degeneration and joint changes, we're just going to end up needing to do orthodontics again in a year or two. So often cases that get funneled to me are juvenile idiopathic arthritis, where a young girl has been slowly developing an anterior open bite. And if we went in and did camouflage ortho and put those teeth back together, but she's not done with her arthritis process or not done with the idiopathic condylar resorption process in the back, she's just going to keep opening back up.
I see. So when you say the idiopathic process, it's just going to keep going until she's like done growing, basically?
So idiopathic condylar resorption typically finishes under 2 years. So whenever I get a case of a young girl with joint changes, I start monitoring her. And after 6 months of no joint changes, I say she's good to go either with orthognathic surgery or camouflage orthodontics if we haven't moved too much. Dentists in general should be looking at the joints, I think, a little bit more than we do, just making sure that we're not having joint changes, because anything that happens up there is going to affect how the teeth are functioning, right? If we have one joint resorbing, we're going to start hitting way harder on this side. And then that crown that you're about to deliver is all of a sudden going to have no occlusion or way heavier occlusion than you thought.
So you just think, kind of as a rule of thumb, for anyone who's taking a pan for whatever reason, just look at the condyles and make sure that they look okay. Okay. I mean, a lot of people should be doing that anyways, but I think it's a good kind of reminder, because I think, there's so many things to look at, and now everyone's seeing such a high volume of patients that it's probably easy for that to get looked over.
If anybody's in excruciating pain, I would not do ortho. If it's a little soreness, I think you're okay, but I would just talk through the patient and let them know it may get a little bit more sore during ortho, but as long as you're comfortable, we can push through this.
Got it. Okay. I'm looking at the questions people asked, and they're like kind of silly. So I don't know. One says, does masseter Botox actually help with this? And my guess is yes, if it's a muscular problem.
Yeah, it can be great. But again, make sure that you're treating the right thing, because masseter Botox isn't going to do anything for joint pain.
Do you also give Botox in other locations because it's covered by insurance, or no, for aesthetic purposes?
I don't do any aesthetic Botox. I just do therapeutic.
So she won't be coming out to Madison anytime soon, I guess.
Honestly, with the rates of Botox in New York, I would have considered it. It's very expensive. Okay. I feel like that's a really helpful kind of just overall idea of what we should be doing with TMD symptoms and like guiding people. I also noticed you do sleep medicine. Is that something that patients are coming to you a lot for?
Yeah, so I'm just starting to grow that side of the practice a little bit more. So sleep dentistry is interesting. For anybody that doesn't know, oral sleep apnea appliances are an alternative to CPAP machines. CPAP machines work by opening up your airway by pushing air down your throat. Oral sleep apnea appliances open up your airway by moving your lower jaw forward during the night while you're asleep. And they're a little bit less effective than CPAP machine itself, but people tolerate them quite a bit better. So if you're going to rip your CPAP machine mask off after 4 hours of sleeping, but you're totally fine using your oral appliance all night, then they end up being about the same effectiveness.
And I had a friend who was experiencing sleep apnea, and so she got one of those oral appliances and it did not work. And what would you say to her kind of as a next step?
I'd always recommend getting a sleep study first, and I'm sure that your friend did.
Yeah.
But depending on what type of closure of the throat you have can change the effectiveness of the sleep apnea appliance. So really the most effective way to know is something called the drug-induced sleep endoscopy. Nobody orders these because they're expensive and not fun for
I was
anybody
going
to
to say,
do.
I'm not like dying to do that.
Right, yeah, they put you to sleep. They take a look at how your throat closes, and a number of other factors.
Good to
And
know that's an option though for like severe cases.
it is, yeah. Sleep apnea appliances in general are pretty good at getting a 50% reduction in your AHI, which is the number of times you stop breathing per hour. And if you're already really severe sleep apnea and we take you down 50%, there's a chance that you could still have pretty significant sleep apnea. But if you're in the mild to moderate category and we take you down 50%, there's a good chance that you're below sub-threshold. And the number of times, maybe you stop breathing 1 time per hour just for a few seconds, but it doesn't bother you and you go on with your life just fine.
What do you think about, sleep apnea is in dentistry is kind of this like hot topic, a little taboo in some respects, not as much for specialists, but more for like general dentists and orthodontists. I am not doing anything besides if palate expansion happens to make it better, that's a win. But I'm curious what your thoughts are on it. If, are people over prescribing these types of appliances, and is there a danger to people getting them and they don't need it besides the financial burden? I just kind of wanted to pick your brain on that.
I think there's kind of 2 categories of sleep apnea appliances. So there's the traditional Herpes appliance, which is basically 2 bite guards and just moves your lower jaw forward and opens up the throat. There's a newer wave of appliances, which I guess I'll say I'm not totally on board with personally. It's in my training, at least, I'm not on board with them, that are attempting to do skeletal expansion in adults, and they're all tooth-borne appliances. And it makes me a little concerned that we are going to move teeth outside the arch.
Yeah, that's weird.
Yeah, so the airway dentistry trend, I think, is a hot button word, and I think there are some more evidence-based airway practices, and I think there are some less evidence-based practices. I think the most evidence-based ones is just the standard sleep apnea appliances moving the lower jaw forward at night.
Why do you think that there's so many people who have jaw pain but aren't doing anything about it?
I think a lot of people either think nothing can be done because they tried something and that they were told to do and it didn't work, or people have pain and they're just pushing through it because they're tough. Or after a certain point of time, they get fed up and do want to do something about it.
Is there a warning for people that by leaving it unattended, that it's going to worsen in certain instances where somebody, they're going to have some kind of an injury or further pain as a result of not addressing it?
Most people with this condition get better on their own. The people that don't get better are the ones that we hear about.
If I'm experiencing jaw pain that's keeping me up at night or during the day, I'm just miserable and it's lasting for 90 days or more, is that the profile of somebody who should not just continue to suffer silently, but should come in and see somebody?
Yeah, I think so, definitely. Not that it is necessarily going to get worse by leaving it alone, but if there's things that can be done, let's push towards that, right?
Is this typically covered by dental insurance or health insurance or none of the above? And so it's an out-of-pocket expense and that's a barrier to people coming in? How does that work?
I am a fee-for-service practice, so I'm a cash practice. Patients will pay upfront. What I try to do is give everybody a super bill to submit if they have out-of-network coverage for their medical benefits. Typically, when these conditions are covered, it's covered under medical. We just can never guarantee because some insurances will play very nice. Some will say that nothing is covered, that it's a dental problem. almost every dental insurance says it's a medical problem. So a lot of patients are kind of stuck in this limbo land.
Does Medicare cover this kind of treatment?
In Wisconsin, Medicaid covers it for kids, but not for adults. Medicare can reimburse. But again, I am out of network, so finding an in-network provider can be a little bit challenging. The other issue is that often the initial exam is covered, but then any follow-up treatment isn't, or that the treatments that we can recommend that we think have the best success of working are not covered.
So yeah, it is interesting because if you had like knee joint pain, that would be covered, right? If you did a steroid injection or whatever people do. So it's like so random that,
Yeah.
but I guess because again, everyone wants to play hot potato. It's not my problem. That's a dental problem.
Right.
That's, and vice versa. So, but real quick, last technical thing I wanted to ask is about migraines. If someone's listening and they're kind of like, I get migraines, I had no idea it was related to what you do. Can you give a little bit of just kind of general information of what someone who is experiencing migraines should know and when they should come to you?
Any primary care doctor can probably prescribe you migraine medication. When I think it's helpful to see a specialist, either a headache specialist or an orofacial pain specialist, is when whatever you've tried one or two things and it's not working and your headaches are becoming disruptive to your life. So for a typical migraine patient, usually the first thing that's tried is something like sumatriptan, which is just a abortant medication. And often that's where it ends, is you try one medication and it didn't work, so they kind of shut down and you just live with the migraines. But there's a lot of other medications out there that can be tried. There's a lot of new medications that have just come out within the past couple of years specifically for migraines that I think a lot of people just miss, either because the physicians that they go to aren't regularly treating migraines or they just didn't know it was an option. So those medications are called CGRP medications, and they're really effective, very minimal side effects. I'm a big fan of them, but I think yeah, getting the awareness out about those medications, or that something can be done beyond just that first line that everybody's tried.
Right. And I think just with any kind of unique problem you're having, you want someone who's seen it a million times. You don't want someone who sees it, twice a year and they don't know what's the most current stuff. Dad, do you have any last kind of medical or business or anything burning questions?
So maybe talk a little bit, Scott, about just how you're finding being in private practice, running your own business. Have there been things that happened unexpectedly that caught you off guard, both positive and negative?
The positive things, I mean, we are way busier than I thought we would be just 3 months out. I had people telling me that it was impossible to do this type of practice, and I think we're doing pretty well. I've been pleasantly surprised by the Wisconsin community and embracing what we can offer patients. From a negative standpoint, I am realizing more and more that I do not understand accounting. Luckily, I've got a good accountant and a financial advisor, but I am very much a technical person, not a numbers person. So that's definitely been a challenge.
Have you been trying to learn to improve your expertise on that front?
I've been trying to, yeah. YouTube has been an all right teacher, but still there are pros for a reason.
This has been a common thing that people say is learn how to do accounting or have an idea of what's going on. If you have a financial advisor and if you have an accountant, why do you need to do it? Why can't it just be delegated out?
Well, we're going to find out if I need to know more about it when tax season comes around. And I realize that I should have been filing something some way that I haven't been doing for the past year.
Got it. Because I could see myself just being like, oh, the accountant's got it. That's not on me.
Were you apprehensive about starting out on your own? I have to say, if I had a problem, I would come see you. You're very
Thank you. I appreciate that.
You seem professionally operating at a very high level, and I like your expertise and I like your manner. You seem very kind of calm and measured in your way of dealing things. But when you first started out, before you started getting good patient flow, and referrals coming in. Were you losing sleep at night when you were, signing the bank loan and,
No,
thinking
I
about all
probably
this
should have been.
investment and that you're out there on the tightrope, on
Mhm.
your own? Talk a little bit about how that felt or how that feels now.
Probably should have been more worried than I was about all of this, honestly. I think the reason why I wasn't as worried is because I knew not many people are doing this. I knew there was a niche and that I could fill it in this particular city. But I've also kind of always been a fan of faking it till you make it. And I just kind of decided that I was going to do this and that I was just going to keep pushing forward until it happened. So I just kept walking through that next step, next step, next step. I think if I tried to do all of it at once, I would be very, very overwhelmed. But we spread it out over the course of almost a year and a half, almost 2 years of planning to open this place.
Do you have any employees or
Just
coworkers?
me and my wife runs the front desk.
Uh-huh.
So that keeps
Nice.
it lean.
Where's your main source of business? Is it from the oral surgeons that are in the floor below you? Is that where most of it's coming
So
from?
let's see. There's a few large group practices around town that have all of them collectively have been keeping me very busy. So there's a big endo group practice, a big ortho group practice, and then the oral surgeons. There's two big oral surgery group practices, and between all of them, they've been sending me a lot of patients. But the other thing that I did was I've visited almost every general dentistry office in town. Before I opened up, I made a list of, I think there's 205 offices in town. I visited in the first month, I had a referral pad and a business card. And so I was handing those out at every office. And it seemed pretty successful because I got a lot of people calling me back saying, hey, I missed you. Can you come back and talk to me? Or a few of the bigger group practices asked me to come back, and I brought lunch and talked to them over lunch, and they've been really good referral sources. So I think having the time where I was unemployed that first month before we opened to just spend every single day going to different offices was a really important for me getting started.
And do you do any social media website type of marketing as well?
Yeah, so my wife works for a social media management company. So she's been pretty instrumental in helping us with that.
And do you get patient flow out of that? I mean,
We
is that
have
working?
not a ton yet, because again, most of it is referral based. And even some of the biggest orofacial pain clinics, when you look at their social media, they have a couple hundred followers. So it's definitely more of a referral based profession. My wife calls it a sign of life, saying that, hey, we are here, we exist, we do post on social media. And I've had a lot of patients mention things that I've posted on social media. So I know they're looking.
That's the
Uh,
thing is like I do it now. If I have any new doctors or anything, and it depends what it's for, I guess. You just want to make sure you're like, it
it's a
feels
real person.
weird if they're not around. Yeah, like, is
Mhm.
this fake? So I totally agree with your wife. I'm excited for you. I feel like you have
Thank
like
you.
a lot to come, and I feel like I'm so glad I met you. Now I have you as a resource that I can learn from, because I am sure I'll have more questions in the future.
Yeah.
We always like to end with like a funny anecdote or experience you had, whether it was
Mhm.
in dental school or at any point that is just relatable for our listeners that you can share with us.
Yeah, I was thinking about that. There was one that stuck out to me in residency. I was like the first or second week of residency. And we were really, well, the first or second week of patient care once we finally got into the swing of things. We just spent the past month or two learning about all these really complex cases and conditions that, are the one in a million things. I had this patient come in, it was a young guy, and he had longstanding tooth pain, upper right, and at the same time, he had a runny nose whenever he got that tooth pain. And I was like, oh my gosh, this is a clear-cut case of trigeminal autonomic cephalalgia, this rare type of headache. And I was so excited to tell my attending. Went in after spending like 2 hours interviewing this guy doing my physical exam. Brought my eval back to the attending, came in, looked in the mouth, and there was just a really big cavity there. And the patient had a runny nose at the same time, and they were completely unrelated.
You were like, I'm a genius.
Yeah, yeah. And so I felt pretty dumb.
Very funny. Good. Well, where can everyone find you? How can they either ask you questions, follow
Yeah.
your social media, all the things?
Yeah, so we are on most social media platforms, Midwest Jaw Relief. My name's Scott Guthrie. You can message me on social media, or you can send an email to our office and I'll respond. That's care@midwestjawrelief.com.
Perfect.
Yeah, please reach out. I'm very happy to talk people through any weird stuff.
Awesome. I have a feeling you'll get some messages after this. So I'm excited to connect people. All right. Well, thank you so much. This was so fun.
Yeah, enjoyed it. Thank you, Scott. Really, really interesting.
Appreciate good talking with you both.
All right. You too. Bye-bye. Thanks for listening to Medical Morons. Don't forget to subscribe, rate, and review.